You don't want me to do the questions, though?
Yeah, you want to do it? Yeah.
Can we do the questions now?
Yeah, so if there were speakers.
The first speakers that we saw,
Yeah.
if there were any questions. This is, I'm just wondering, Sonia, she's still here, right? Would she be willing to take questions? Yeah. And Simon. Hello? Is this on? Hello? Hello? Can I have your attention, please? I'm just... Hello? Thank you. Thank you. I just want to take this chance. Sorry, we didn't have the logistics for the questions and answers. And all of our presenters from this morning are willing to take questions from anyone. If you have any questions for either Sonia, Simon, the patient experiences, or Dr. Soucy or Dr. Morin. Raise your hand.
OK, Simon va se promener avec le micro. C'est important que vous parliez dans le micro.
Oui.
Je vais poser ma question en français. Pour Dr. Soucy, je me demandais, tu sais, comme pour les grades ou le KY 67, est-ce que ça peut changer dans le temps? Tu sais, comme moi, j'ai été diagnostiquée il y a 2 ans, j'avais, admettons, grade 1 primaire, grade 2 dans le foie, mais le KY 67, je pense qu'on ne l'a pas refait. Est-ce que ça se refait ou on laisse ça comme ça?
Oui, on peut refaire avec le nouveau matériel. À chaque fois qu'on a du nouveau matériel, on le refait, puis ça peut changer dans le temps. Donc, c'est intéressant de le refaire. Puis ça dépend aussi, donc, quand on a un échantillon, par exemple, une biopsie, il faut comprendre que la biopsie, c'est un échantillon de la tumeur. Donc, c'est peut-être 2 mm d'une tumeur de 3 cm, par exemple. Donc, ça se peut que dans cet échantillon-là, ce ne soit pas la même chose qu'à côté, parce que dans la même tumeur, c'est variable aussi. C'est pour ça qu'on va dans les endroits où c'est le plus prolifératif. On va les sélectionner quand on a la tumeur au grand complet. Donc, quand on a juste un échantillon, ça se peut que l'aiguille qui a pris l'échantillon ne tombe pas nécessairement dans la zone la plus proliférative. Donc, c'est bon de le faire à chaque fois qu'on a du nouveau matériel.
Donc, aussitôt qu'il y a une progression de la maladie ou de la grosseur peut-être de métastase, je ne sais pas, là, ce serait mieux que l'oncologue demande à faire une nouvelle biopsie. Bien, préférable.
Ah, ça, je vais laisser.
Bien, je ne veux pas. OK.
Oui, parce que là, Dr. Soucy, c'est une excellente pathologiste, mais je ne vous dirais pas que c'est une clinicienne qui traite les patients. Donc, dans l'absolu, c'est un petit peu complexe comme question, parce que la littérature n'est pas très claire non plus, pour l'avoir toute lue régulièrement, puis confronter comme les expériences cliniques à ça. C'est que le problème, c'est que le KI 67, qui peut prédire le pronostic, à la base, la littérature est sur le primaire. Puis il y a beaucoup de gens qui ont des biopsies qui sont faites sur les métastases. Puis là, en fait, les gens, ils prennent le KI des métastases, pareil comme celui du primaire. Mais en fait, on le sait très bien, c'est excessivement variable, comme le disait Dr. Soucy, puis ça peut changer d'une biopsie à l'autre. Donc, oui, le KI 67, c'est un marqueur important. Oui, c'est important dans notre prise en charge, mais on ne va pas répéter des biopsies aux 3 mois pour être sûr que ça n'a pas changé. Fait qu'en fait, parfois, quand on a une question clinique particulière, quand il y a une métastase qui progresse de façon plus importante que les autres, quand elle n'allume plus au gallium-68 et qu'elle allume au PET-FDG, on peut vouloir répéter une biopsie pour savoir si celle-là particulièrement s'est dédifférenciée. Fait qu'on peut être amené à faire des biopsies pour remesurer le Ki-67 quand il y a une question clinique pertinente. Mais on ne fera pas ça de façon suivie régulière pour avoir un suivi dans le temps du Ki-67 parce que celui-ci, il correspond à rien, en fait. Il ne nous avantage pas, puis il ne nous aide pas à prévoir l'évolution clinique d'un patient. Fait que c'est pour ça qu'on ne va pas le faire.
Merveilleux, merci beaucoup.
C'est aussi pour toi, Dr. Soucy. Je vais le répéter, I'll repeat in English just in case. Je voulais juste savoir si ça arrive que excuse-moi, le mot m'échappe, mais mitotic count puis le KI67 sont variables, comme vraiment différents quand vous faites.
Oui.
Je vais juste répéter en anglais. If the KI67 and the mitotic count are vastly different, what happens?
Oui. Alors, quand on a notre décompte mitotique, je vais répondre en français, je peux aussi répondre en anglais. Là. Quand on a notre décompte mitotique, puis notre index de prolifération avec Ki-67, effectivement, donc, ils peuvent être semblables, mais ça peut arriver aussi que le Ki-67 soit plus élevé. Parce que ça ne couvre pas exactement la même région, dans le fond, exactement la même chose dans le cycle cellulaire. Donc, ça se peut que ça soit un petit peu plus élevé, le Ki-67, pour l'index de prolifération. Puis nous, ce que nos guidelines nous disent de faire, c'est de prendre toujours le plus élevé. Donc, on va aller souvent, parce que ce n'est pas tous les centres qui ont accès nécessairement, premièrement, au logiciel de décompte automatique, certainement pas. Ce n'est pas tous aussi qui ont accès à des plateformes immunohistochimiques. Donc, selon, ça se peut qu'ils aillent avec l'index mitotique, qui valide le rapport, qui demande après ça à un autre centre hospitalier de faire le Ki-67, puis ça arrive plus tard, mais au moins le rapport est sorti avec l'index de mitotique. Donc, il y a plusieurs choses qui peuvent arriver dans les centres périphériques, mais dans les centres où on a accès aux deux, on prend le plus élevé. Oui, bien, on peut refaire notre compte mitotique sur différents. C'est qu'avec le compte mitotique, on peut utiliser différentes zones de la tumeur, tandis que le Ki-67 est fait sur celle qui est notre appréciation de la pire zone. Donc, on le fait sur une des lames, puis ça va être celle-là. Donc, en général, on essaie de prendre où notre compte mitotique est le plus élevé. Donc, oui, mais même si on choisit bien notre lame avec le compte mitotique le plus élevé, ça se peut que ce soit vraiment plus élevé, mais on va y aller toujours avec le plus élevé.
The highest number.
The highest number always, but we have to make sure that the positive nuclei in the Ki-67 are on tumor cells. Well, that's another thing that could happen if you're not used to do that.
Yeah.
You can see the endothelial cells, the vessels that can be positive. The lymphocytes can be positive. Yes. So if you're not aware of that, that could also result in not different.
Yeah. So, in fact, I'm almost always asked for rereading, for specialty rereading, when we have extremely high Ki-67 and low mitotic count, which is like a classical pitfall that the pathologists that are not used to read neuroendocrine tumor can fall into. And most of the time when they are like in a small center, they don't read Ki-67 quite often, they misdiagnose the cell for lymphocytes. And so that's why we ask a rereading. And classically, it's when it's a high Ki-67 and a low mitotic count, which, because most of the time they should at least correlate in the same range. I don't want them to be perfectly the same, but it's should be in the ballpark range.
Thank you, both of you.
Other question? Autre question? Yeah.
Thank you. I have to first apologize because I didn't quite understand the answer, so I don't know if I'm giving a redundant question. The Ki-67, if you initially have your resection, and so you've got your pathology, and then you get a gallium-68, and then you don't get a gallium-68 again, is there a way to tell whether the Ki-67 has changed?
Yeah, well, actually, as we said earlier, if you have FDG, radioactive sugar, PET-CT that is positive, and you have a loss in the uptake of your dotted 8 gallium-68 PET-CT, you may want to take a bite of it in biopsy to see if the pathology has changed for that particular lesion. That's it.
Any sign of hypsotrypsy coming? Hypsotrypsy? It's the new treatment that you're going to say.
We have no data for that particular treatment. I'm sorry, all of us.
No, I have a friend in the US and they're just starting, she's starting it in July. Thank you.
Hi, everybody. As a patient, and we are broadcasting live today, and many of the patients speak English, and unfortunately, we missed the entire conversation that you guys just had, and we don't understand, and it would be very beneficial if we could do it in English. I'm sorry. Or as well, if that's okay with you. Thank you. Many of us patients have missed the conversation, so. And like I said, we are broadcasting live, so there's a whole audience of English-speaking people that didn't understand any of that.
So about the Ki-67?
All the conversations that were in French, unfortunately.
So quickly, I will try to repeat. So the biopsy. Okay, so the first question was about do we have to redo the Ki-67? And as I said, I'm a pathologist, so when there's new material that comes in the lab and it's a new endocrine tissue, a tumor, we redo the Ki-67. I am not the one who takes the decision to redo the biopsy. This is the clinician's decision to redo or not a biopsy. Once the biopsy enters the lab, then I will redo the Ki-67. We redo everything, but we have to understand that it's a sample. So it's 1 or 2 millimeter wide, and it doesn't represent the whole tumor, and there's variability in the Ki-67 within a tumor. So yeah, that's that. And for the other question that was about the discrepancy between the mitotic count, so if there's a discrepancy between the mitotic count and the Ki-67 result, so what do we do? So we usually go with the highest number, which is usually the Ki-67, and there is, so I don't want too much of a panic, but sometimes there's some mistakes if you're not aware that some cells other than the tumor cells can be positive. So you have to only count the tumor cells and not other type of cells like vessels, like lymphocytes or inflammatory cells. So you have to be kind of used to read those Ki-67 to make the right assessment. So that was that, and then
Yes, and finally, we were wondering if we could see some changes in the molecular imaging for a lesion that we suspect that the Ki-67 is getting higher. Basically, if we have a lesion that doesn't show any more dotatate uptake and show FDG uptake, this might be a dedifferentiating disease. And at this particular point, we may want to take another biopsy. We don't do a biopsy for every progression, but if we suspect that the disease is changing, is getting very more aggressive, and it doesn't show the receptor anymore, we may want to take a bite of that new lesion. And PET-CT may help to identify that lesion. All right? You're welcome.
I just want to make sure, because when I was asked for the presentation, they told me it doesn't mind if I do my presentation or French and in English, so I've prepared everything in French, and now you're telling me it's not working, so that this is an issue. Oh, okay. Yeah, it was too expensive. Okay, perfect. I don't mind. Yeah. So I'll speak in English then, and we'll see whatever.
Excuse me for you, I don't speak English. I understand, but I don't, for my question, it's, OK. Je vais le dire encore en français. Là, je ne sais pas à qui m'adresser, mais c'est pour la différence entre la dotate 68, quand on fait les scans, les PET scans, puis celui qui est au DJ, en tout cas, l'autre au sucre, là, dans mes termes. Moi, je fais du PPRT, c'est nouveau. C'est ma première traitement, mais je me demandais pourquoi, biologiquement, notre corps, l'année passée, je n'étais pas éligible, il ne flashait pas. Là, il flash. Biologiquement, pourquoi nos métastases vont être modifiées? Je ne sais pas si la question est trop pointue ou je vais trop loin, là, mais pourquoi tout à coup, j'ai fait beaucoup de chimio par contre, pourquoi tout à coup, là, ils sont réceptifs? Je suis très contente qu'ils soient réceptifs, mais je me posais la question, pourquoi maintenant?
Je vais répondre en français, puis je vais répondre en anglais après. En fait, ce qui se passe, c'est que quand il y a des tumeurs comme la vôtre qui ne surexpriment pas les récepteurs à la somatostatine parce qu'ils ont une composante peu différenciée, fait que là, ça répond encore avec Dr. Soucy à l'hétérogénéité du cancer. Fait que donc, il y a plusieurs clones différents dans un cancer, et puis il y a des clones mal différenciés qui ne vont pas surexprimer le récepteur à la somatostatine parce qu'ils sont mal différenciés, qu'on ne va pas bien voir au gallium-68, mais qu'on va bien voir au PET scan FDG parce que ça veut dire qu'ils prolifèrent rapidement, ils se divisent plus vite. La chimiothérapie tue les cellules qui se divisent rapidement, mais ne tue pas les cellules qui se divisent lentement. Donc, habituellement, dans la tumeur neuroendocrine, les cellules qui sont le mieux différenciées, c'est-à-dire celles qui surexpriment le mieux le récepteur à la somatostatine, poussent moins vite. Fait que ceux-là ne sont pas tués par la chimio. Les autres qui poussaient vite sont tués par la chimio. Fait que là, en fait, quand on vous réimage après plusieurs cycles de chimiothérapie, il reste le contingent qui surexprime le récepteur à somatostatine, qui n'a pas été tué par la chimio. Puis c'est celui-là qui est sensible à la PRRT. Tandis que l'autre contingent n'aurait pas été sensible à la PRRT.
Oh, merci. Bon, ça a valu la peine que je fasse la chimio, juste pour ça.
So I explain back in English. So basically you have in most of the cancer, multiple cancer, there's an heterogeneity about the tumor cell. So basically you have multiple cell population. This is true in every cancer, and it's also true in neuroendocrine tumor. The particularity is that the neuroendocrine tumor who are proliferating quite fast, they don't overexpress the somatostatin receptor. So you need the somatostatin receptor to be treated with PRRT because the molecule is going to bind on that receptor. So if you don't overexpress it, basically the PRRT is going to just radiate everywhere in your body and not specifically in the tumor cell. So basically what she described is that she had chemo first and then afterward PRRT because the first dotatat that she had was negative, and then the second dotatat after chemo was positive. So this can happen. This is quite rare though, but this can happen in the situation that we've killed most of the cells that were high proliferator, which were not overexpressing the receptor. So those one die with the chemo. The other one that were overexpressing the receptor are less sensitive to chemo because basically chemo kills the cell that are dividing. So if the cell are not dividing, the chemo is not going to kill them. So the cells which overexpress the receptor are better differentiated with lower Ki67, so it means that they proliferated less. So they're not going to be as susceptible to chemo. So basically, when she received her chemo, it kills the cell that were not overexpressing the somatostatin receptor, and we were left with the cell that were overexpressing the receptor. So that's why on the second gallium scan, there was a signal that time that wasn't there at the first time. So that's why they decided to go with chemo first and then PRT. But this is a rare situation. This is not all the patient, and this is quite complex. It's different from one to the other, but this is a possibility.
Any other questions?
Oui.
Oui, oh, Mathilda.
Je vais peut-être le faire en français et en anglais. Mon anglais n'est pas tellement bon, mais en français, je ne sais pas si ça peut être hors sujet. C'est juste que je me demandais, quand quelqu'un reçoit un diagnostic de NET, est-ce qu'il y a des tests qui existent pour la famille immédiate ou, frères, sœurs et les enfants? Alors, when someone is...
I can do it.
Well, I'm going to try it. So, thank you. So, when someone is diagnosed with a NET, what's about like the immediate family, about the testing? Is there something that can be done I guess that maybe biopsy is, you don't know where to do the biopsy because it's maybe it can be done. So, is there any testing?
Genetic.
But maybe it's out of subject.
Donc, pour la TNE, en fait, épithéliale, qu'on appelle là, classiquement du petit intestin, du pancréas, il n'y a rien pour l'instant qui est connu au niveau génétique. On a fait des analyses génétiques à la plupart de nos patients parce que c'est des patients jeunes qui ont des cancers, puis on les envoie toujours en génétique en se disant on va peut-être trouver quelque chose, mais pour l'instant, dans la TNE, il n'y a rien qui est rapporté à part des situations particulières qu'on appelle les MEN en anglais ou les NEM en français, les néoplasies endocrines multiples de type 1. Puis là, il y a 1, 2, ça c'est classiquement ce qu'on connaissait, puis là maintenant 3, 4, 5. C'est ça. VHL aussi, mais les VHL, c'est une situation bien particulière. Habituellement, on connaît dès le départ, puis c'est surtout les féos qu'on cherche. Fait que, c'est des tumeurs neuroendocrines non épithéliales, les phéochromocytomes, ou les cancers médulaires de la thyroïde, qui sont des tumeurs neuroendocrines, mais qui sont des tumeurs neuroendocrines non épithéliales. Donc, les tumeurs neuroendocrines classiques, du petit intestin, du pancréas, il n'y a pas... À part les MEN1 pour les pancréas, il n'y a rien de connu au niveau génétique. So basically, for neuroendocrine tumor, there's nothing known up to now as a genetic component except for MEN1, 2, 3, 4, 5, which is a specific situation associated with most of the time neuroendocrine tumor of the pancreas or the duodenum with hyperparathyroidism and pituitary tumor or pheochromocytoma with medullary thyroid cancer. This is quite rare, but most of the time this is family component. Most of the time are not like they're not somatic mutation, but they're familial mutation. So. And there's also VHL. There's a couple more. There's MAX. There's multiple other one. But for the epithelial neuroendocrine tumor, up to now, there's nothing known. We have now, I think, 3 MAX patients, which, I mean, MAX was described as a pheochromocytoma mutation, or more probably paraganglioma mutation, and which is extra-adrenal pheochromocytoma, basically. So, and those 3 patients, in 2 of them, we found epithelial neuroendocrine tumor. So now we're wondering if we should study that more because this is kind of weird. This is not described in the literature, so we were wondering if we should dig more into that. So maybe there, at some point in the next 10, 20 years, we'll find something, and then in every patient with a neuroendocrine tumor, we'll test for a specific gene, but for now, there is nothing.
OK. Je pense que s'il y a des questions qui reviennent, on les posera après la prochaine conférence. Ça va? Puis je suis très heureuse d'inviter Dr. Mercier à venir enfin faire votre connaissance après avoir entendu parler de vous par différents patients et patientes. Fait que bienvenue.
Merci beaucoup de m'avoir invité, c'est bien gentil. Je vais essayer de faire ma conférence en anglais, puis je commence ma présentation en français, parce que moi, je suis francophone. Donc, Frédéric Mercier, je suis chirurgien, je travaille au CHUM. Ça va faire 6 ans maintenant, que je suis spécialiste de la tumeur neuroendocrine. En fait, je fais presque 50-60% de ma pratique, ce n'est que de la tumeur neuroendocrine. Je fais d'autres choses aussi, mais je me spécialise beaucoup en tumeur neuroendocrine. Donc, je vais vous parler de la chirurgie des tumeurs neuroendocrines. J'ai gardé ça super simple parce que l'objectif, c'est pas de parler de chaque détail technique ou des complications possibles de chaque chirurgie. C'est pas ça l'objectif. L'objectif, c'est d'essayer de voir qu'est-ce que la chirurgie peut apporter. So, before we start, just go with a quick introduction in English. So, I'm here to speak about the neuroendocrine tumor, the surgical portion of the neuroendocrine tumor. I just wanted to keep it really simple, okay? The point is not to discuss every surgery in detail because every surgery is different with every patient, so it's impossible to go over everything. It took me like 15 or 16 years, so I don't think I'm going to be able to do it in 10 minutes, okay? So, first of all, this is something you've probably heard extremely often. Neuroendocrine tumor are rare tumor. This is still true, even if they're more frequent than it was, they're still considered as a rare tumor. And the specificity of it is that it can arise basically in every organ in the body, which is an issue. Because when you take all GI neuroendocrine tumor together, there is still not the first cancer. They're less than colon cancer and like somewhere close to gastric cancer. So it means that regarding the number, it's still quite rare. So it's quite common that most of the physicians, they don't have many information about that, because also the other issue is that those tumors, since they're able to produce hormone, they give weird symptoms, and most of the time this is very different from one patient to the other. So since the heterogeneity of the presentation is so wide, it's difficult for a clinician that's not used to see those tumors to make everything together. So that's what makes it really particular. So what are the principles of surgery? So basically, there's 2 mindsets in the surgery when we go for NET. And when Dr. Ale is giving a talk about surgery in neuroendocrine tumor, she's always saying for neuroendocrine tumor, this is different, it's a slow-paced disease, we don't have the same principle or the same goal for the surgery than to other cancer surgery. So let's say for gastric cancer, we are extremely aggressive and we want to hit extremely hard, so basically it's more like a sprint. But for neuroendocrine tumor, most of the time, it's not like that at all. We're not aiming for curative purposes. We're aiming more for quality of life purposes, prolongation of life. So we don't want to be too aggressive and gives you a lot of symptoms afterwards. So the objective is not the same. Sometimes we're lucky because the diagnosis is made before multiple metastases, or at the point where we could still try to resect all the disease and makes it a curative objective, but this is most of the time, I would say it's about a third of the surgery that we aim for. So 2/3 of the surgery are going to be in the objective of decreasing the symptoms, either obstructive or hormonal secretion symptoms. And there's multiple ways to get that objective, to get to that objective of having the best quality of life and managing the symptoms. And the other thing that we want to prevent, that we want to be sure that you're going to be able to receive all the treatment. If we're too aggressive, if we try like big liver resection, and sometimes we prevent you from getting other line of treatment, because then we're getting into other issues. So most of the time in neuroendocrine tumor, when we go for a liver debulking, we try to be as precise as possible. You want to remove only the tumor and keep the tissue that is sane. And it's the same thing for the small intestine. So you go in, the point is to take out the mass, but you don't want to take too much small bowel out, because if you take too much small bowel out, then you have a short gut syndrome, you have diarrhea, you have difficulty to digest, so it's extremely complicated. So it's always a balance about where you want to go with the patient and what you want to try to achieve at the same time. So the NET are what we call like a surgical disease. So those are diseases, most of the time there's a cancer that are really susceptible to chemo. Some of them are really susceptible to radiation. Some of them are better treated by surgery, and the neuroendocrine tumor fall in that category. So most of them, as we were discussing, the Ki-67 is low, so it means that the tumor doesn't proliferate that much. So we know that the chemo is not useful for a lot of people. So some proportion needs chemo and it's really useful. Some don't, and it depends on every situation. So most of the time, neuroendocrine tumor are going to be treated by surgery at some point. And this is totally depending on the primary tumor. So this is not as true for pancreas as it is for small bowel. So almost 100% of the small bowel are going to be operated at some point. And this is not the same for pancreas. This is not the same for lung. It's not the same for uterus, because it's possible. It's not necessarily the same for thyroid, but it depends. But most of the people are going to go at some point for surgery, or at least should see a surgeon. So I've put some of the primary there. Same thing, I didn't do an extensive list because it's impossible. There's too much disease and too much site, and every situation is different. But most of the time, for gastric, there's like two possibilities. First possibility, multiple endoscopic procedures. So this is not what we call surgery. Most of the time it's done by a gastroenterologist. It's not done by a surgeon. So basically we try to remove all those small tumors that we call type 1. And the second track, basically those are surgery that looks like adenocarcinoma of the stomach, so like a formal resection with lymph node removal and everything that really could look like gastric cancer. The only difference is that you're not going to have neoadjuvant chemotherapy and adjuvant chemotherapy. So most of the time for stomach, with those two scenarios, we cover almost all the possibility. Those are the gastric surgery that we could be, those are the main two possibilities. So basically, in the right one there, you could see it's a partial removal of the stomach. So it can be like half, a third, 2/3. It's going to be dependent on where's the tumor and when you're going to be able to remove everything. And classically, that's what you're going to hear. This is called a montage Y de Roux, because Roux is the name of a surgeon who invented that the way of reconnecting the bowel together. Because So we chose, most of the time we choose this montage because there is a bit of less symptom involved with the biliary tract. You can see there's the bile tract is connected and there's a segment there so it can prevent the, what we call gastrite biliaire, so bile gastritis, because when you connect the duodenum directly to the stomach in a montage that we call bilrot 2, there's going to be some bile that's going to go through the stomach, and this could give symptoms to a lot of patients. So that's why most of the time now we prefer to do Y de Roux. And then on the right side, you could see here it's a total gastrectomy, so basically we remove all the stomach. So it's possible to remove all the stomach. It takes a while, though, to be able to eat, I wouldn't say normally, but more close to normal than before the surgery. This is never going to be the same. For sure, if you need a total gastrectomy, you're never going to be able to eat as you were eating before the surgery. But that being said, over time, after 6 months, a year and a half or so, most of the patients are able to go on with like 4 meals a day and 2 snacks or something like that. So it's never going to be like a 3 meal and like in the same quantity that you're used to, but still possible to remove all the stomach. Even some people are like, I'm gonna be able to survive and eat afterwards. So basically we create a small pocket of small intestine, and over time it grows and that pocket become bigger, and you're still able to eat. So this is the scenario where there's a lot of small tumor everywhere, and we can remove them endoscopically. You could see those are removal spots. So basically, the GI, most of the time they're going to be GI, but some surgeon will also do it. You inject a produce, which is Voluven, which is like a starch liquid, a liquid with starch in it, and dye. So you could see why it's a bit blue. It's just because of the dye, basically. And you lift the tumor up. So when you remove it with a small a snare, basically, it's like the snare for the. It's like a metallic circle, and you could squeeze it on the tumor, and you can eat it. So it's gonna cut the mucosa and leave. What we see there, it's the submucosa, so you could see the fiber, the muscle fiber. You could see it's a clean cut, and it didn't go through the stomach. So basically, it's helped us to notice that the resection that we've done is good, that there's no cancer left, but at the same time, we didn't get through the stomach, because that would be an issue if you get through the small bowel or the stomach. So this is specifically for what we call type 1 gastric neuroendocrine tumor. We do those resection quite often, and it could be like 50, 60, 80 tumor that we remove in the same session. And then most of the time they're gonna have to be checked every year. So this is quite common. Small bowel neuroendocrine tumor, this is one of the most common, and this is really my specialty. I take care almost only of that. And the things that we're having, and it's complicated in those tumor, most of the time the issue is not from the primary. You can see the primary there. It's right, like behind, there's a small lesion in the small bowel, but the problem is not the primary. The problem is with the red arrow. The red arrow basically is showing lymph nodes that are calcified, so that's why you see a white spot in the middle. It's because it's calcified, which is quite a common reaction for neuroendocrine tumor. And you could see that there's like a big mushroom form, like a tumor right there. And this is sitting on the vessel that we call the superior mesenteric vessel. So those quite important, those vessels. They vascularize all the small bowel. So basically, if you cut the superior mesenteric artery or you cut the superior mesenteric vein, you could lose all the bowel, which is a problem because then you end up with short gut. So This is a patient I operated a month ago or so. I didn't put her name, so that's good. So you could notice, I mean, it's a bit complicated. I'll try to show it on the screen, but you can notice the tumor there, it's going on top of the vein. So basically, it's eating like the anterior wall of the vein. So we could still remove all the tumor from the surrounding tissue and then put a small clamp on the vein, and I resected just a small portion of the vein wall, and then I've just like closed it with the suture, and the vein was intact, and I just needed to remove a small portion of the small bowel and a bit of the colon, and that was about it. So this looks quite easy. You just go in, you remove the tumor, and that's it. This is quite complicated, and that's why most of the time the surgeon in the community center will get an opinion from us because they're not sure if they're able to remove it. And if they go in and they're not able to remove it and I need to go back, this is way more complicated because then there's scar tissue, and the second surgery is always more difficult than the first surgery. So that's why I'm trying to convince them to send me the patient before going in, and then if I think it's easy and they can manage on their own, I'm just gonna tell them, go ahead, I don't mind, it's perfect that you do it on your own. And if I think it's too technical or complicated, or maybe I'm not even gonna succeed, it's better that I try on my own, than because probably my rate of success is a bit higher. For sure, I do this every week, so if it was lower, then that would be a big problem. So the point is, the first surgery, it's always the best shot. So you want to be sure that the surgeon's going to be, he's not going to say no when he could say yes, and he's not going to try to make it work when it's impossible, because the consequences on both ends are really not good. So you want to be sure that you go for what can be done. It's rare, and the advantage that we have in that kind of disease is that now with the PET gallium and everything beforehand, the planification is really good, and the likelihood of success when we think that we can succeed with the radiology, it's about 90% correlation. So there's about 10% of failure, which isn't that bad for that kind of disease. So pancreatic net, second most common for digestive tract, and as Simon was speaking, this was is a type of cancer. There is a multiple location in the pancreas. So basically, we divide the pancreas in two more like important anatomic portion. There's the head, and there's the body and the tail that goes together. So surgically, that's the way we approach things. Either we remove the head or we remove the rest. And removing the rest is a way smaller surgery than removing the head. So removing the head of the pancreas is one of the biggest surgery in general surgery. It's called a Whipple, or in French, a DPC, duodenoppancreatectomie céphalique. So it's quite complicated surgery with a high likelihood of complication and a change in life for sure after that kind of surgery. So in this case, the tumor is in the body, so you could aim for like removing the body and the tail of the surgery. Most of the time, we need to take the spleen at the same time as the tail of the pancreas, because there's a lot of lymph nodes that are in the splenic hilum, which is a zone with multiple vessels and quite complicated to remove the lymph node with the spleen staying in place. So we have a tendency to remove the spleen at the same time, and basically when you're above 20, but probably more above 40, doesn't impact as much removing this. Basically, there is no impact at all. It's just for some vaccine that need to be given to protect against some specific kind of bacteria. I'm just going to stop there because I could go on and explain to you a lot of other surgery, but I think the point is just to know that There's multiple possibility. Most of the patient at some point are going to discuss with a surgeon. And anyway, if the surgeon that you've seen as question, but the referral center are there for those people, and we're there for that basically.
Is there any questions for Dr. Mercier before we head on? No? Okay, we're going to go. Dr. Ma is not here. Oh.
She's just parking, so we'll get the next.
We're going to switch the two next speakers. So we'll go with Dr. Maoudi. Maoudi? Sorry.
Bonjour à toutes et à tous. For the sake of time, I will speak in English. I will do my introduction in French. Je m'appelle Amin Massouli, je suis fellow en angio au CHUM à Montréal. Et aujourd'hui, on va parler du traitement des métastases hépatiques de tumeurs neuroendocrines. So, very happy to be here today among you. My name is Amin Massouli. I'm a fellow in the interventional radiology department at CHUM Hospital. We'll speak about the hepatic metastasis from neuroendocrine tumors. Just to get an idea, who here had heard about interventional radiology? Okay, wow, a lot of you, perfect. So in the next few minutes, we're going to discuss what we do in interventional radiology and the role that interventional radiology has in the treatment of hepatic metastasis of Cnets through a technique that we call the transarterial embolization or the blend embolization. So to go to the next slide, just have to click here. Perfect. So we're going to discuss, first of all, about why we can treat this type of lesion and what are the techniques that we use to do so. Then we'll discuss about the goal of the intervention, but also the vascular access, the management of the patients after the intervention, and finally, we will conclude. So, hepatic metastases of Cnets are typically hypervascular. So this is an example on the CT. Hypervascular means that the lesion needs a lot of oxygen and a lot of nutrients to grow. So you know that what brings oxygen and nutrient to the organs and among others the lesion are the arteries. The arteries are like rivers that flow through the body and bring nutrient and oxygen to the organs. And compared to the liver, the healthy liver, the lesion will need more nutrients, more oxygen than the healthy liver, and will require more arteries also than the healthy liver. So the aim of the intervention is to occlude these arteries that will reach the lesion. So we want to embolize, this is what it means, to occlude and block the arteries, to prevent the oxygen and the nutrients to reach the lesion, and finally, partially or completely kill the lesion. So, but how do we do to block an artery? So basically, the principle is pretty simple. We enter the hepatic artery, and then we advance into the arteries that feeds the lesion, and we inject some product, it's called microparticles, that you see on this picture, and that will block and occlude the arteries. We do that with the help of what we call a catheter. So it's the plastic tube that you see on the right side of the picture in the artery that will help us to navigate through the arteries. So this part was more theoretical. Let's move on to a more practical approach. So now you understand well the meaning of transarterial embolization. So it's transarterial because we want to go to the hepatic artery through the arteries, and it's an embolization because we want to occlude these arteries. So the day of your intervention, this is an angio suit, an angio room, sorry, when we work every day. And so the day of the intervention, you will lie down here on this table with the X-ray tube that will pass over you to create pictures that help us to navigate and to see where we are. So it's like a GPS. And the pictures will be projected on the big screen that you see on the picture here. So, but we cannot puncture the hepatic artery directly because the hepatic artery is deep in the abdomen. So we have to use another entry site. We have to choose arteries that are more superficial to puncture these arteries and through them enter into the hepatic artery. So we have two choices. The first one is the femoral axis. So the femoral artery is the artery that is located at the level of the groin, and it's a superficial artery, so we can puncture it to enter into the body and go to the hepatic artery. Here I have a small and short video that you can find on YouTube that shows the entry sites to the femoral artery. So first of all, we do this intervention under local anesthesia, not general anesthesia, and this is the local anesthetic to numb the tissue. Then we puncture the femoral artery, and by this moment, so the skin and the tissues under the skin are numbed. So the patient should only feel a slight pressure as we insert the devices. So we secure our entry site with a sheath, but it's a little bit technical, but the sheath will remain during the whole intervention. It helps us to insert our devices. And now we'll insert the catheter. So it's the black one that you see here. We enter into the aorta, so it's a big artery in the body, in the abdomen. We can shape the catheter, so it's not mandatory. So the catheter is really used to select the hepatic artery. So now the catheter will enter into the hepatic artery now, and with an even smaller catheter, we advance into the hepatic artery and in the artery that will feed the lesion, as you see here. So once in the target vessel, we inject the microparticles to block and to occlude the artery. So the aim, as I said, is really to prevent the oxygen and the nutrients to reach the lesion, cutting off the oxygen supply. After the intervention, once we're done, we remove all the intravascular devices, and we might compress the groin, the artery, to help the artery to heal. Or we can use what we call the closure device. So it's like a gel that help us to seal the opening that we made into the artery. Femoral access is a safe technique for this procedure. We'll monitor the patients for about 4 to 6 hours after the intervention to be sure that there's no bleeding at the puncture site. And the patients have to lie still, so without moving her or his leg during this period of time to ensure a full recovery of the artery. So the next technique is called, for the femoral access, so the risks are really low, and the risk includes minor complications such as bleeding or a stable hematoma, so it's like bruising at the puncture site, or more severe complications such as infection of the puncture site and other complicated medical terms, but basically it's like a dissection, it's a tearing in the wall of the arteria. But this last one, we can manage it during the intervention. But these complications, you have to know that they are really rare. So we make everything to prevent them and to avoid them. So the next axis is the radial axis. The radial artery is the artery that we feel here at our wrist, okay? It has a huge advantage over the transfemoral approach because it significantly reduces complications associated with the transfemoral approach. But the technique, the procedure is exactly the same. So we puncture the radial artery, we enter into the hepatic artery, inject our product, and that's it. So when we want to do the radial axis, we do a simple test before the test of the Barbeau, just to make sure that there's a flow in the artery. The complications of radial axis are also really rare and include radial artery occlusion, trauma to the radial artery, but again, they are rare and we do everything to avoid them. After the intervention, so we remove our devices from the artery, we can place a compressive band around the wrist to compress the artery and help it to heal. So this is a compressive band, and the patient keeps the band about for 1 to 2 hours. But as you see on this picture, the compressive band has a huge advantage over the transfemoral approach and the closure device and the compression, because it allows for more mobility of the hand, mobility of the patient, less immobilization of the patient. So it's really a huge advantage. This is just a picture of the microparticles that we use, that we inject into the arteries, the target arteries. So as you see on this picture, they are like microspheres, and the sizes go from 40 to 1030 microns. We use usually 100 microns to 400 microns to embolize the artery. So one last thing that I have to say is that, as you know, maybe the liver has two parts, the left side and the right side of the liver, and sometimes several lesions can appear in the liver on both sides, on the left and on the right side. So to avoid overloading microparticles into the liver, we never treat both sides together. So we treat always one side, and 2 weeks later the other side. So for example, the right side, the first session, 2 weeks later we treat the other side to allow for the other parts to recover during this couple of weeks. So this procedure is generally well tolerated by patients, but we have some side effects. Most of patients will experience post-embolization syndrome. So this includes variable pain, nausea, with or without vomiting, fever, fatigue, transient increase in liver enzymes. But these side effects are manageable with medication. 9 to 15% of patients may require an extended hospital stay, but it's normally completely manageable with medication, painkillers, and anti-nausea drugs. Another side effect that is really rare is the carcinoid flare. So it's like a carcinoid crisis that we see with hormonally active lesions. But to prevent this side effect, we inject octreotide before the intervention to avoid this side effect. So the symptoms are hypo or hypertension, but once again, these symptoms are manageable at hospital with just simple medications. There's also some complications. There are also rare liver infection after the procedure and cholecystitis, so it's an infection of the gallbladder. And once again, we have medications to control these complications if necessary. But once again, we do everything to avoid completely these complications. So, to conclude, transarterial embolization is a very effective treatment to treat symptoms related to hepatic metastasis from neuroendocrine tumors, and it provides a high degree of disease control with a good safety profile. Thank you for your attention, and feel free to ask questions if you have any. Oui.
Un, deux. OK, parfait. Merci pour ta présentation. Je voulais savoir, est-ce que tu sais si ce genre d'intervention-là, là, on parlait comme plus du foie, est-ce que c'est pratiqué sur d'autres organes qui sont touchés par le net? So, in English, thank you for your presentation. I'd just like to know, do you know if this kind of intervention can treat like other organs than liver?
Donc, vous savez, souvent en science, pour faire ce genre de traitement, on a besoin de beaucoup de données, beaucoup de data. Et à ma connaissance, pour l'instant, les data qui sont très robustes concernent les métastases hépatiques. So for this kind of intervention, we need a lot of data, robust data, to perform this kind of procedure. And to my knowledge, the treatment, this interventional treatment, for this interventional treatment, we only have robust data for these metastases in this location, and not robust data for other locations.
Thank you so much. I found that absolutely fascinating. I had no idea how that was done. I have two questions. Number one, as a patient, I want to be put to sleep for this. So can you tell me why you wouldn't put a patient to sleep?
Because general anesthesia is not as simple as we think, okay? It includes some complications. We have to mobilize an anesthetic team, etc. So it's more complicated to do it with general anesthesia. We can do it with general anesthesia when, for example, the patient comes for his or her first session, and we see that the patient experienced a lot of pain, that it was really difficult for him or her. So we say, okay, for the next session, we can maybe try with general anesthesia. But we have other techniques to ease the pain, like it's called portal block, I think. So we can inject anesthetic product directly in the liver to numb the liver, if you want, and it helps a lot also to ease the pain. So for the first session, no, we don't use general anesthesia, unfortunately.
Okay. And just the other question I had was, you said the wrist is way better.
Yeah.
So why are some people still going in through the groin then?
Because I think that it's a matter of experience with the radial axis.
Right.
It's something pretty new for us. When I say new, it's like maybe for the last 10 years that we began to do this kind of radial axis for different kind of intervention. But yeah, I think it's a matter of experience, and sometimes the radial artery has not a good flow. Okay, so we prefer to do it with a femoral approach, and also, yeah, it's a matter of access in how the artery is, if the artery is healthy or not, if the artery is calcified or not. So maybe once you use the radial access, but we cannot use it because the artery is occluded.
Amin,
Yeah.
excuse-moi de t'interrompre. So the thing is that the catheter evolved a lot in the last 5 to 10 years, and basically what was possible then is not the same thing as what is possible now. So they didn't have the right angulation, the stiffness to be able to go from the arm to the liver because the angle are quite sharp. But I mean, they do it quite often in the wrist, but still in some patients they're not able to because the artery is too small, too fragile, it busts.
Yeah.
So sometimes they still have to do it with the femoral access, which has been classically described like the access because it's more direct, basically.
Yeah,
you go
exactly.
in and there's less tangle, there's less turn, so then the catheter, and since the catheter evolved a lot, they can do it with more sharp turn and everything, but still, and they can do stuff they couldn't do 20 years before. They're way more precise than they were before. They treat a specific segment of the liver now. They wouldn't be able to do this before because the catheter were too big, and now they can get access to a really small type of artery, which is different than it was before.
During a session, how many tumors can be treated, and what is the usual size of the tumors that can be treated? You know?
Yeah, so yeah, sometimes in some patients there's a lot of metastasis, like maybe 10 or more metastasis, for example, in the right side of the liver. So we cannot selectively go into each artery and embolize each artery. So we embolize from what we call the right hepatic artery and embolize all the right liver. But because the metastases are hypervascular, the flow will go mostly into these tumors, okay? And the healthy liver will be protected. Because there's also something that I didn't explain, but so the liver has a double vascularization. The arterial part, the arterial vascularization that is about for 25% of the vascularization, and the liver has also another system that we call the portal system. Maybe you heard of it. So it's a venous system. It's not an arterial system, and the portal system vascularizes about 75% of the liver. So even if we inject some particles into the healthy liver, the 75% of the portal system will protect the healthy liver, but not the tumor, because the tumor is hypervascular. So mostly fed by arteries and not by portal veins.
Okay, so basically what you're saying is that during a session you can get to most of the tumors.
Exactly,
Okay,
from the right hepatic artery, because we embolize basically the whole right liver.
Merci pour votre présentation. Je voulais juste voir avec vous comment vous sélectionnez les patients qui vont recevoir les antibiotiques pré-procédure, donc immunosupprimés ou autres, ou tout le monde va le recevoir. And how do you select patients that will receive prophylactic antibiotics, so pre-procedure? Is it immunocompromised patients or everybody?
I don't have any idea for the yeah, maybe Dr. Mercier could answer because it's basically his job.
So basically, we give antibiotics to any patient who did a previous liver abscess, which is one. It's kind of rare, but it's still one category. We give antibiotics to any patient that had what we call like a bile tract. En français, on dit des voies biliaires qui ont été opérées. Fait que c'est des patients qui ont eu des CPRE, des sphincterotomies. So basically, if your bile tract is open, so if you had a sphincterotomy with CPRE, basically you have bacteria that come from the bowel that go through the bile tract. So in this case, you have a higher rate of liver abscess. So this. So immunosuppressed patient in NET, it's quite rare because there's a lot of patients that doesn't get chemo. So since they don't get chemo, they're not what we call immunosuppressed. So this is a rare occasion, and some... No, so if there's advanced disease of the liver without biliostasis or like cholestasis, we don't need antibiotics. So it's not the burden of the disease that give the rise to the antibiotics. It's more if there's already bacteria in the bile tract, basically. So patient who needs a stent and that kind of stuff, they're going to need antibiotics. And patient that they don't have bacteria in their bile tract, they don't really need. So some patients, they have really like what we call sector cholestasis or biliostase. So basically, some of the segment of their liver are going to be excluded because of the disease. It's kind of rare, but it's possible. And in this case, they are at really high risk of liver abscess, so they get. So I just want to say a thing about the portal block, which can be really useful. Yeah. But we had some issues with portal block, and we know that it can cause some bile duct pas hémorrhagie, necrosis, bile duct necrosis, because of the lack of arterial. Basically, it can impact the arterial supply of the bile duct, which is also dependent from the arterial system. So yes, the liver is way more, the liver parenchyma, the liver cells, are way more vascularized from the portal system, but the bile duct are only dependent on the arterial system. So the portal block can raise the pressure surrounding the common bile duct, and it can like prevent those small artery from bringing blood supply to the artery, to the bile duct system. So it's really useful, but it can still lead to other complications.
Do we have time for one question? 2 minutes. Oh. Okay. Can you touch a bit on how do we determine the size of the microparticle?
How we choose the sizes?
Yeah, exactly.
Because we know that the arteries in the liver, we know approximately the sizes of the liver arteries. So we know that we have to firstly use 100 microns sphere to really go deep into the artery system in the liver. And then we use bigger spheres like 200 microns and then 400 microns and more if necessary to block the bigger arteries. So maybe I can come back to my picture. I don't know if it's possible. To see one of the slides? No problem. So so this is how we choose the size, but it's pretty the same sizes for everyone. So we always begin with 100 microns and go to 400 or more microns to occlude the artery. We do several control during the embolization to be sure that, thank you very much. It's the precedent one, I think, yeah. So you see that it's not really clear on this picture, maybe more on the video. So to embolize the small arteries that are really deep in the lesion, we have to use smaller particles. And for larger arteries, the artery that feed the lesion, we have to use larger particles.
So does this depend a bit on where the meds are in the liver, or it's patient-based?
No, it's pretty always the same sizes. Okay, it's never smaller than this, and we can use smaller particles to begin with, but it's not necessary, and the data showed that 100 microns was a good size to begin with. But the important is, the sizes are really important, that's right, but the most important things is the control that we make at the end of the intervention to make sure that the arteries are occluded, or that the flow is really is not fast in the arteries. So maybe just a few more seconds to see these. So as you see here, the first microspheres will be small microspheres to go really deep in the lesion, you know. But after that, and the smaller particles would block the larger particles, you know. So the last particles that we inject are bigger than the first particle that we inject.
Okay, thanks.
Thank you.
Thank you very much.
Thank you very much. Sorry, there's never enough time for questions at these conferences. So Dr. Ma is here. Thank you.
All right. Hi, I'm Dr. Ma. Thank you once again for Cnets for this kind invitation. It's my first time this year, so be kind, everyone. I'm a new medical oncologist. I work out at the Jewish General Hospital. I'm affiliated to McGill, and obviously one of my primary interests is gastrointestinal tumors in general and neuroendocrine tumors in particular. So thank you once again. I'm greatly honored to be here. These are my conflicts of interest that have no impact on what we are to discuss today. As you can see, I don't have only neuroendocrine tumors that I treat, but mainly all of the digestive tract. So very, very briefly, because they gave me 15 minutes to go through systemic therapy, which I thought was very ambitious. It actually took me a long time to try to bear it down to sort of bite-sized chunks. So essentially, just because it does impact our treatments, I think it's always important to keep in mind the classification of NET, and we're kind of going to go through a couple of the options that we do have in terms of systemic therapy. And I am not going to talk about PRRT, although I kind of want to, because that's the most exciting thing that's been happening to NET in the recent years, but I will stay away from it. Okay, so just in terms of vocabulary, I think it's really, really important. Sometimes we're kind of rapid firing these terms out in discussion, and we have to remember that neuroendocrine neoplasms is a broad umbrella, and I would argue it's not one disease, it's multiple diseases, and even things that we do refer to as NET is actually, although they're well differentiated, they actually encompass different grading, and each of these different grades, low grade, intermediate, high grade, will be treated and respond to systemic therapies very differently. And we have to keep in mind that these are very different from things, for instance, like neuroendocrine carcinoma, which are poorly differentiated. And I think Dr. Susi kind of went through the classification of NETs earlier this morning. And these are also treated very differently than how we would treat a well-differentiated epithelial NET. Okay, so today I thought I would focus, kind of bear down on NET very specifically, so well differentiated. And this is the WHO, so the World Health Organization classification that came out very recently in 2022. And as you all know, it is very much a pathological diagnosis where we kind of look at the proliferation rate of the tumor cells. And you can actually kind of stain it, see it under the microscope. You can see how fast the cells are dividing. You can have a marker called Ki67 that looks at the proliferation rate of these NETs. And again, grade 1, grade 2, grade 3 as differentiate between low, intermediate, and high. It's fairly intuitive, but again, all of these three different entities are treated very differently and will respond differentially to our treatments. Furthermore, to even complicate things further is that, they talk about NET, but the reality is that NET can be many places, and a lung NET will not necessarily behave the same way as a midgut NET, which will not necessarily behave the same way as a pancreatic NET, which is very different than a colorectal NET. And not all of these tumor sites will have been included in the trials that we will kind of go through in terms of the systemic therapies, and not all of them will respond the same way. So again, it's just, although I was asked to talk about NET in general, I would argue that, they kind of asked me to talk about systemic therapies for like 20 different diseases. So I'm going to try to kind of bear down a little bit. The other thing is, we do often talk about chromogranin A in the, especially in the more advanced settings where, we will be asking chromogranin A, for instance, in clinic. No, that is not a perfect test, okay, and that there are different reasons why chromogranin A will be positive or negative. And so just to keep in mind that there's no perfect blood test to measure the disease course. And this is just, the differential of why chromogranin A might be elevated. And so just to keep in mind, in clinic, if sometimes there are variations in chromogranin A, that this is really not kind of the end-all and be-all of the disease. Okay, so as I said, I kind of had to pick and choose a little bit what I wanted to talk about over this 15-minute span. So I thought that I would start with low-grade NET, so essentially kind of focusing on the grade 1s, the mitosis less than 2, the Ki67 less than 3%. One can argue that some of what I will talk about could be applicable to grade 2s, but again, grade 2s being less well differentiated, a little bit more aggressive than grade 1s, might respond differentially to something like somatostatin analogs, which we're going to go through. And this is a completely different beast than the NET grade 3, which I think my colleague after me will be speaking about as well, which are very much more proliferative, more aggressive, entre guillemets, and more responsive to something like cytotoxic chemotherapy. Okay, so essentially when we talk about NET treatment, especially in the low grade, we're talking, so again, I'm not going to talk about the surgical or local treatment because my colleagues are a lot better positioned than to talk about it than I do, but there's two goals that we do keep in mind whenever we start systemic therapy for NET: symptoms, and obviously tumor control. Okay, and when we talk about symptoms is because we know that NET is driven by this enzyme called somatostatin, which is released in a variety of different organs in the brain, in the eyes, in the gut, in the pancreas, and all of these organs can develop different secretion products that can cause these carcinoid, these paraneoplastic syndromes. And again, this is more for reference. Each of them are actually quite rare, but when they do happen, they can be quite debilitating. And so these are, so the somatostatin analogs were developed because, again, the NET do express somatostatin quite heavily, and so somatostatin analogs were developed to target, so this is a form of targeted therapies against somatostatin. Now, what is very interesting is that although I said, well, one of our main goals is to control the symptoms of excess somatostatin production, the vast majority of neuroendocrine tumors are actually non-functional. So 60% of patients have non-functional NETs as opposed to functional with the syndromes that I had kind of listed previously. Now, on the market currently, there are two somatostatin analogs, and I'm not going to talk about the generics, which is a kind of a different beast that's coming onto the market but not quite here yet. We're used to seeing octreotide and lanreotide. These are the dosing schedules. So as you can see, all of them start at Q4 week dosing. It is, so the octreotide is an intramuscular, so a little bit deeper injection, as opposed to lanreotide, which is a sub-Q injection, which came onto the market after octreotide. And if you look at the reason why we use somatostatin analog, it makes a lot of sense. Okay, it inhibits somatostatin receptor 2 and 5 preferentially, but as you can see, where it is most expressed is in the pancreas and midgut, and it is in the pancreas and midgut that we often use somatostatin analogs, although we take the liberty to extrapolate what we know in midgut pancreatic data to other tumor sites that might not have the same bulk of data just because they're so rare that we just don't have the studies the same way that we have in pancreas and midgut NET. So the PROMID study, which already came out over, 10 years ago, compared essentially octreotide injections, intramuscular, to placebo intramuscular every 28 days. And I'll just point out that this was really for midgut, so digestive, small intestinal NET. And essentially what they were trying to look at is, well, are we slowing down tumor progression? Okay, so that was, for statistical purposes, kind of their main goal. And then they had like secondary endpoints as well. And not to belabor the point, but I mean, obviously it was a positive study, which is why we kind of have it on the market these days, is that this brought it to regulatory reimbursement. Obviously, as you can see here, the orange line is the octreotide, and the blue line is, well, nothing, it's placebo. And you can see here that the time that it takes for the disease to progress and to grow was doubled with the use of octreotide. Then subsequent to that, there was the equivalent study, but with lanreotide. I just told you there were two on the market, so octreotide. So, you know, they did their study, and now Clarinet is the lanreotide study that came out. And essentially, they compared pretty much the same thing, but instead of using octreotide, they used lanreotide. I would just like to point out that unlike the PROMID study, they actually included grade 2s as well, which was interesting. And so if you kind of compare the two studies, the one with octreotide and lanreotide, you can kind of see the differences here. So the PROMID study, which is kind of the first time we actually kind of thought about somatostatin analogs in NET, was really only for midgut. So if you're going to actually follow the studies, you have to keep in mind octreotide was best studied really in the midgut setting, as opposed to the lanreotide, which was a little bit more pan-gastrointestinal, so multi-sites. And you can see the criteria of inclusions were slightly different. So were they functional, non-functional, grade 1, grade 2? And essentially, you know, they kind of even had tumor burden in terms of the volume occupied by the disease. And you can see, again, what their cutoffs were also different. So I would argue Clarinet was a lot more permissive as a study. So in general, if you're going to have patients and you're really going to kind of abide by what the literature, the body of literature says, oftentimes I find lanreotide has just a little bit more robust data, just because, again, they had more inclusive, more permissive inclusion criteria than octreotide. That being said, though, you know, when you kind of talk to experts in the field, and you kind of, especially to patient advocacy groups, in general, there's no kind of comparative trial. So in general, which one is better than the other one? I would argue we don't actually have definitive data on it. When lanreotide was developed, you notice I said sub-Q, because the idea was that it would be less painful than an intramuscular injection. And there was actually an interesting study that kind of did patient interviews, patient surveys, essentially looking at which one they preferred. I quoted it there. It wasn't a big study, but interestingly enough, there didn't seem to be that big of a difference. So in general, I think ultimately it comes down to the patient who's actually getting the treatment. So, you know, if they tell me, look, the IM was going super well, and then you switch me to this thing, and like I get a bruise and like hives, and it's like horrible every time, obviously I'm not going to insist and like say, well, I have better data for lanreotide, you know, like, no. You know, at some point, just as body of like real life data, we do really feel that they're probably pretty equivalent. And this is usually what you get started on at diagnosis. Again, focusing on well-differentiated grade 1, arguably grade 2 NET. And it always depends, again, on how you present, how fast your disease is growing, how urgently do we think we need to get a control of this. But usually it does represent kind of the backbone of NET treatment. When you kind of start looking at, okay, well, you are on somatostatin analogs, whether you know, upfront at diagnosis, a little bit later on when the symptoms started appearing, or when we realized that even though it's a grade 1, it should not have been growing, but it is kind of growing a little bit faster on subsequent scans than we would like. And you know, whether you're a medical oncologist or your hepatologist or your surgeon starts you on somatostatin analogs, what happens when that stops working, right? And so you'll often see everolimus being quoted as one of the very common systemic therapies. This is a form of targeted therapies, I guess. It targets something very specific called mTOR. And for those who kind of explore cancer world, there's very definite pathways of cell growth that comes back over and over and over. And this is one of those that you'll see not only in NET, but you'll see, for instance, in breast cancer, in colon cancer. So this is not a drug that is exclusive to NET. And actually, I would argue most of my experience actually is not from using it in NET patients, which remains a relatively rare cancer. So it's a pill. It's a pill of 10 milligrams once a day. And the reason why we use it is because of these RADIANT studies. So most of the time when they get reimbursed, there's usually a nice name of a study that compares the drug that got approved versus standard of care. And as you can see here, the RADIANT study was looking at functional nets of the gut. That's the snake thing that you see on top. So functional nets, so you actually had to have carcinoid syndrome or excessive serotonin production, and it compared the addition of everolimus, again, to a somatostatin analog. Okay, so the backbone remains the same. The somatostatin analog, we would argue, remains the same, but we added everolimus to it. And you can see here on the right-hand lower side that the curves do separate. The blue is the everolimus. There is a little hint that it might be a little bit better, but clearly it was not as impressive as the curves I showed you with the clarinet or with the somatostatin analog. And although I didn't go through the data, and hopefully I know there's a very experienced IPO nurse who's going to come later to talk to you about nursing in NET, is that everolimus is not the easiest pill to take for those who've had experiences with it. Although we have this idea that, IV, it's going to be really strong, I would argue that, that my experience across tumor sites is that sometimes those pills, they're very tricky. They're very tricky. There's a thing that happens when you have to absorb the pill through your digestive system that makes it toxic. So with everolimus, there's a lot of what we call mucositis and inflammation of the mouth, and you can imagine how problematic that is when it comes to impacting your taste, your nutrition, especially when trying to fight cancer. Anyway, so that being said, so we looked at the gut, and they were like, oh, it kind of works, so let's try it a little bit more broad, and this is what came up with RADIANT 4. So instead of just the gut, we're talking about the lungs as well, which is a very rare form of NET, well differentiated again, and they allowed non-functional, so not just those who had diarrhea or flushing, etc., but non-functional NETs, which is again the majority of our patients. So I was happy to see this because, again, it became more applicable to kind of more of the patients that I actually do see in clinic. And you can see here the separation of the curves again, and it seemed to be beneficial whether it was the lung or the gastrointestinal tract. Again, the addition of everolimus. This is just a follow-up, and this was very interesting because if you can see on the blue graph bottom right, OS is overall survival. So in well-differentiated, slowly growing disease, it's actually very, very hard for any clinical trial to demonstrate. It's logical. You would think, well, if it takes them longer for it to grow, longer to progress, et cetera, that it would translate into an overall survival. But it's actually very hard to prove it on the data because it takes so long to follow everyone, and you can imagine people move, etc. And so it takes really a long time to actually demonstrate what we, I would argue is a very, very important endpoint. A doctor, is this going to make me live longer? I would argue that it's actually a very hard question to answer when it comes to very slow-growing diseases. But I was very happy to see this was one of the updates from the RADIANT 4 that you can clearly see, the curve starting to separate. There's been efforts, and this is just one of the many negative trials, meaning that bevacizumab, which you will see in other gastrointestinal tumors, it blocks the production of our arteries, and we just went through a whole talk on how to, embolize the blood supply to the tumor site. So it's kind of logical to want to use a molecule that prevents the production, the creation of new blood vessels, and bevacizumab is one of them. Unfortunately, it was negative, which is why you won't see it being offered in clinic. I thought I would quickly mention telotristat, which is kind of for refractory diarrhea related to carcinoid syndrome. So oftentimes, when you have diarrhea and carcinoid syndromes, your physician will often mention the somatostatin analog and Imodium. You know, those are kind of our two big backbones, sometimes Lomotil, et cetera, and, you know, a lot of dietary modification, and oftentimes it is a little bit imperfect. This was actually the first in class to actually show some benefit, but very marginal in terms of this refractory diarrhea. So although it's only 40% of the patients, and I would argue the majority are kind of at least livable. The symptoms are kind of livable with somatostatin analogs. We still have some of those that are extremely symptomatic no matter what we do in terms of medical treatment. So this is kind of a summary slide. Again, I didn't have time in 15 minutes. I'm sure I'm going overboard. But to go through all of the treatments one by one with the studies to support it, but these are kind of the numbers that will come out if you kind of look at them. And again, octreotide, lanreotide are really our backbones, and the study population is really as per the study, where was this studied, right? So everything else, if you happen to have a rectal net, you have to be a little bit careful when you look at the data. Perhaps it won't behave like what the studies are telling us it will behave. But obviously, how many rectal nets are there? We will never be able to run a study like they ran a study for the midgut or the pancreatic net. So sometimes in medicine, we have no choice but to extrapolate from, you know, logically from similar diseases. I didn't, you know, I thought it would be a little bit much to kind of go through every single chemotherapy options that there are. I kind of listed them here. Just to keep in mind that chemotherapy targets best DNA replication. So something that replicates very slowly, sometimes the chemotherapy has a hard time seeing it because it's just not proliferating as much as, I don't know, a lymphoma or leukemia, for instance. And so the response rate to chemotherapy, especially in low-grade, well-differentiated, remains, you know, usually around below 20%. So it is extremely modest, and usually this is very much reserved when everything else fails, including PRRT, which, as I said, I won't mention. And again, you know, I think that there's the complexity of not looking only at the grade when it comes to the net, but also to keep in mind where the net arises from. And this is just a summary table to kind of try to help you piece it again. And again, sometimes we just don't have studies, and sometimes we're stuck extrapolating it. So, you know, if you're like, well, you know, I have a lung net, and where's the study, doctor? Probably he'll tell you there's no study. Like, you know, he should be honest with you and say, look, I don't have a study, but the pathological look of it and the behavior of it is very similar to, for instance, a duodenal net, so it just makes sense to use it. Very, very quick word on something called well-differentiated high grade. So again, I mentioned the grade 1s and the grade 2s, so somatostatin analog, the everolimus, and when we're really stuck cytotoxic chemotherapy. And again, I'm not going to mention the PRRT. But in the well-differentiated high-grade net, know that these are the people who have, it's a very weird entity that's only recently been more recognized, and it is somewhere between the very indolent, well-differentiated, and the neck. Remember, I mentioned you the neuroendocrine carcinoma, which are poorly differentiated. So they're kind of like this in-between entity. They do comprise a minority of the nets, and because they're kind of in between, there's even less functionality. So the less differentiated you are, the less they'll behave like the initial tumor cells, and the less likely they're going to produce somatostatin. Most of them are from the pancreas, although a lot of them will actually have somatostatin receptor positivity on imaging. So oftentimes, high-grade tumors are treated with something called platinum etoposide, which are forms of chemotherapy. And usually when we say high-grade, this is kind of our first reflex because we're used to treating, for instance, small cell lung cancer, which is a high-grade NEC. But know that NET, which are well-differentiated high-grade, and again, as I said, it's like this kind of zebra in the room, it doesn't respond well to traditional chemotherapy. So you're kind of stuck, right? I just told you, well, it doesn't really behave like the well-differentiated, and nor does it really behave like the very poorly differentiated. You're kind of in the middle of both. So what can you do? The bottom line, and again, they're going to, obviously my colleague will be going through it a lot more with the PRT, is that you kind of do a mishmash of both, okay? When you're kind of in between, you're kind of stuck to do an in-between treatment. And usually, if somebody is positive for somatostatin, we will be giving a somatostatin analog because biologically it makes sense. Do I think it's going to hold as well, it's going to control the disease as well as a well-differentiated grade 1? No, because probably not all the cells are somatostatin driven either. These are just a few of the chemotherapies that we use, okay? So CAP-TEM is one of them, and I think some of you might be familiar with it because it's one of our more common chemotherapy protocols. As I said, I'm not going to talk about PRT. And if you look on the far right hand, the everolimus I spoke about in the grade 1s, well, suddenly there's no, can I point? So suddenly you see here what worked with the lower grade suddenly doesn't seem to work at all in the higher grade. Okay, so again, I think that it is a particularly difficult beast to treat because it doesn't respond to chemotherapy, like the poorly differentiated, and it doesn't respond as well to what we give in the well differentiated. In the interest of time, I'll kind of skip this, but this is one of those, so ESMO, the European Society of Medical Oncology, is one of our biggest oncology congresses that we have every year. And, you know, we are always trying to improve obviously outcomes, and especially I was very happy to see that suddenly this orphan disease where we didn't have any studies this year seemed to finally get the light that it deserved, in that, you know, suddenly we're having studies come out trying to look at whether or not a variety of treatments, some of them new, some of them already on the market, actually can help these patients. And so, again, it kind of supported, again, that everolimus doesn't seem to work very well with high grade. It's very, very modest, the answer. And so I think that, in general, what we use in low grade probably works a little bit in high grade, but it probably needs to be combined with something else, something a little bit stronger. And just because immunotherapy is like kind of the hot topic, you go into any kind of cancer site and you talk about immunotherapy, not everyone responds to immunotherapy the same way. Not all tumors respond to chemotherapy the same way. And because NET is such a rare, unfortunately, disease, you know, we don't have a lot of data. Most of them has been studied in NEC. Okay, so the high grade, poorly differentiated, but the NET, the well differentiated that we're used to treating with lanreotide, there's very, very little data. I mean, like, I'm quoting studies with 19 patients, with 30 patients. So this is very, very modest data, and you can see it's very, very modest outcomes as well, with response rates of 25, 15%, and time to progression of only about a month or two. So again, even though immunotherapy is kind of sexy and exciting and it doesn't mean that it's going to work. And unfortunately, the signal has been very challenging to try to piece out with neuroendocrine tumor. And again, I would argue that probably is because we just haven't figured out exactly which population would benefit from it. Because as I said, I don't see NET as a single disease. I see it as 20, 30 different entities. And even within that, everyone does behave differently too. So this is kind of a complicated summary slide. So this is what they tried to tell me I should do in 15 minutes. And so I kind of said, okay, I'll try to at least make a narrative that makes sense. But know that, again, these are not firm guidelines. These, you know, what I mentioned is one of those things that I always say, you know, guidelines are like a recipe book. Okay, if you follow a good oncologist, he'll help you become a chef, okay? And so I think that all of these things are guidelines, and, you know, these are things that needs to be done to gain regulatory approval and reimbursement for our drugs. But within that, I think everyone is very, very individual, and their NET will behave very, very differently. Even though on pathology it says grade 1, it might behave like a grade 2. Even says it's grade 2, but hey, if you've been on lanreotide for 10 years, well, that does not sound like a grade 2. So I think ultimately it's one of those things that has to be individualized, and your NET, like you, kind of changes with time as well, right? So it does need to be adapted as well. So that's my little 2 cents on systemic therapy.
Thank you, Dr. Ma. Unfortunately, we're running a little bit late, so we'll have to, we're fine? Okay, great. Any questions for Dr. Ma? Thank you.
Hi, what would be your experience with using Lenvima or Lenvanitab?
Yeah, so that's an excellent question. It has been shown in some phase 2 studies to have activity again, and I would argue where I get the most bang for my buck when it comes to any tyrosine kinase inhibitors. So tyrosine kinase inhibitors are a group of pills because they're all oral, they target again different pathways of the cell proliferation. And Lenvima, like sunitinib, which I didn't mention, it was like kind of on one of my table lists. These have all been studied in kind of phase 1/2s, and although they're not officially reimbursed in certain cases, sometimes in Quebec at least, we have the freedom to apply as a patient d'exception, where you can have that wiggle room of saying, look, I know there's no study, but there ain't gonna be no study. So this is the data that I have, and so you can actually apply to the government or the insurance company, depending on how the reimbursement works, and you can ask for it. Now, Lenvima, again, all these tyrosine kinase inhibitors do come with a very specific set of different side effects that need to be monitored adequately. And because they're pills, sometimes I think we kind of forget, even, it's kind of very intuitive, you're like, it's a pill, it should be better than this IV thing that you have to be hooked up every 3 weeks for. Lenvima, like Sutent, like everolimus, does require assiduous follow-ups if we're going to not cause issues. And a lot of these TKIs, they do have hepatic metabolism as well, which does become tricky as well when it comes to treating people with hepatic disease with potentially hepatotoxic treatment. So I think that, Lenvima, I have had great success with it. I've had no success with it. So I think it is, especially in somebody who's assiduous about their follow-ups, and because they do come in 4 milligram doses, to be very kind of aware of how to play around with the medication depending on the side effect. And I think this is one of those that, again, we're here, there's a recipe, and then there's like a recipe adapted to you. And I think that's the TKIs in particular, you really need to have a strong partnership with your oncologist to say, hey, look, I know when this happens, I need to go down to 4 milligrams, or I need to skip 2 days. And I think that's really important to document for your physician, because we're obviously not there dispensing the medication. And I think you have to also be very aware to yourself how well you tolerate different doses of medications as well, because they are tricky. They are tricky.
Okay, so this is probably a very ridiculous question, but when you're talking about if you're on lanreotide and progression is slow, so you would have, tumors kind of appear over a period of time. Is that the intent of staying on lanreotide, is that it's slowing down? Like, what is the definition of slow? Does that mean you'd stay on lanreotide maybe a couple of years?
That's a tough question. Okay, so first, although I said NET are like 20 different diseases, I would argue if you have more than one metastasis of NET, like more than one site of disease, it's probably a different NET at every single site of disease. I would argue that, if you were to biopsy every single one of your liver lesions, probably maybe 1 or 2 are grade 2s. Most of them are grade 1, so maybe most of the grade 1s will respond very well to your lanreotide, but you have a lesion that grows. Okay, you have a lesion that grows, I'll probably send you off to one of my colleagues in interventional radiology or surgery and say, look, the bulk of the disease is very, very well controlled. Can you do something about this? Knowing that it's not addressing the whole of the disease, but the whole of the disease is usually well controlled with what I do, and then I send them for very specific treatments. Strictly speaking, if you go on clinical trials and you ask what a clinical trial will tell you in terms of progression, is that if you do have a new lesion, regardless of really, and I'm really simplifying it, but if you have new lesions, it's usually considered a failure of therapy. Now in clinical world, we know we have a limited amount of treatments to offer. It's not as if I have 10 different somatostatin analogs that work as well if I, piece them out. I don't have that luxury. So obviously any treatments, especially a somatostatin analog, which is usually one of our more benign and I would argue effective treatment, is that we will try to stretch it out. And how do we stretch it out? Is that we kind of address the problematic areas as they go along. But strictly speaking, yes, it is a progression on somatostatin analogs. So generally when we say it's more delaying, I shouldn't say slow down, it's delaying the progression of disease. So technically if a systemic therapy is working, you want it to be stable or shrinking and stay shrunk type thing. When it starts growing again, that's where we say it's progression on the treatment, but whether or not that triggers a change, that's a very different story.
Okay, thank you. That's really helpful.
Is that okay? Yeah, go ahead, Emma. I just want to know, has there ever been a study with octreotide injection versus lanreotide? No.
No.
There hasn't been. Okay.
No.
Thank you.
And this has, and no, that's it. So whether or not it is, when you develop lanreotide or you develop any drug, you want to bring it on the market. Like that's kind of the goal of it. So obviously they'll try to maximize that chance, and neither company want to take the chance of losing their market share, because obviously if they compare and one clearly goes superior to the other, all the market shares will go to that. And the concrete truth also is that it's a very expensive thing to run. Like we're talking, I don't know, millions of dollars, I guess. I don't know. More than that. I'm still naive, So the reality is, especially if they don't think they're going to gain a lot of market shares to do the study's just not going to happen. And sometimes this is where you see investigator-led studies, which is not pharma-sponsored, but sponsored through the Canadian Foundation, et cetera. But obviously, they don't have the budget that these big pharmas have, so they'll be very nitpicky about which ones and how many we can run. And there's a lot of these questions that run in medicine. This is the classic one for Cnets, but there's just so many of them running, and we know we will never have the data because the companies will never want to put in that budget for not that much of a market share. That's kind of the business side of things.
So as far as clinicians go then, in practice, do you guys have a preference, or is it patient preference? How do you...
I would always argue there's top is patient preference, okay? But obviously if you've never had a somatostatin analog, well, there's really no way to know. There are certain factors that do come into mind when we do prescribe, especially when it's the same in-class medication, because again, these are kind of debates that we do have over and over. Sometimes the reality is, especially, these do get developed with time, so sometimes things get grandfathered in. We're only human. This is what we're used to doing. So sometimes you'll see, well, I've always given this, it's always been working well, etc. Two, however, is that things like support programs. So I would love to have a pivot nurse for all of my, net patients. The reality is I don't have a single one where I work. Okay, the Glen has one. I don't know if the Shim has one, but it's not every place that has a nurse for net. And so a program that will offer nursing support associated with the drug or delivery of the drug, well, I think that's very interesting. Suddenly I'm like, well, you're telling me you're going to deliver the drug, that there's a nurse that's going to call you a week later to see how you are, who will call you, to get your Imodium to you because, it's giving you diarrhea after the injection. These are very valuable complementary assets. And if I had, the absolute support from the clinic where I work, obviously these were not considerations, but these are concrete considerations that happen, especially, if the patient lives far. A little bit confused. I'm a little bit worried. Are they going to remember that, Q28 days, to call the CLC, to go to... So, these are things that do percolate through our minds. But ultimately, if you have a bad reaction to one, obviously our first reflex will be to switch to another. Also, to keep in mind, lanreotide is not accessible necessarily in all hospitals when you get hospitalized. So let's say you have, I don't know, a heart attack. It happens. And you're there and you're due for your lanreotide dosing. The hospital only carries a certain amount of drugs. They don't carry the whole gamut. So in the hospital, we have access to octreotide because it comes in a short-acting form, and the short-acting form, we use it for other things. And so that's what the hospital covers. So sometimes patients will be switched to octreotide while in hospital unless you bring your own lanreotide to the hospital. What we have to dispense to you will be octreotide, and this is true for a variety of drugs, so just to keep in mind. I've had one patient tell me like, oh, I love octreotide, and so I just kept him on octreotide after his hospitalization. I was like, of course, I'm not going to argue again. I'm like, you're the one receiving it. I will never tell you, especially with the lack of data. Now, if I had data, I would still discuss it with you, because ultimately it's you who has to live with the treatment on a daily basis. So ultimately, it's your body, your choice. We didn't choose to have this disease, but for the minimum amount of stuff that we can choose, I think that, the discussion really needs to be there, and that would be on an ongoing basis as well.
Basically, when you break down for the clinician's perspective, it goes through, one is sub-Q, one is intramuscular, which is a bit different for several patients. If you're anticoagulated and everything, clearly, I wouldn't give a preference to something intramuscular because there's a higher risk of bleeding. Then after that, the other thing is that one long action needs to be covered by short acting because it's going to take about 3 to 4 weeks to act. And the other one is going to act in 48 hours. So if you have like a lot of secretion symptoms and you don't want to give yourself like 3-4 weeks of short acting 3 times a day, one is better than the other, but there's clearly no data. It's just that it's going to act faster, basically. But over time, more clinicians are comfortable with the older one because they've used that for 20-some years, and then the newer one just came out 5 years ago. So they're more used to titrate the other one, and they're not used to titrate the new one. So there's less comfortable with that.
But as far as like disease progression, no,
They're
there's no
similar.
data.
They're similar, yeah.
At all.
Yeah.
Okay, thank you very much.
Yeah.
You guys.
We're going to keep going.
All right.
Yes. Thank you so much.
Thank you, Dr. Ma. Our next presenter is Dr. Nicholas. Let me try to say it. Dr. P.
Dr. Nicholas is my patient sometimes, so.
Okay, hi everyone. Just going to start the timer. Yeah, there you go. So my name is Dr. Pluznikov, Dr. Nicholas, if you want. I'm going to talk today about peptide receptor radionuclide therapy, PRRT, for the people familiar with it. Dr. Morin, my colleague, already covered some of the aspects of the prerequisite. Before doing PRRT, we have to do imaging. I'm going to build on that. So what is PRRT? Well, it's molecular radiotherapy. We use like small molecules with small peptides, very small, like smaller than antibodies. And they can move about like the system when we inject them through the bloodstream. And they're going to target very specific receptors. In the case of Cnets, we want to target the somatostatin receptors. The SSTR usually type 2. And it's overexpressed in the majority of Cnets. We need to confirm the presence of those receptors. That's why we do imaging beforehand with gallium-68, for example, dotatate, and sometimes FDG to rule out like the differentiated tumors. The radiopharmaceutical we're going to inject is dotatate, of course, and it has high affinity for this target, and we're going to inject high-V. So you have a system that will deliver very specific or very targeted amount of radiation to the cells or to the tumor that overexpress those receptors and sometimes the cells around it, the other tumoral cells. That's a slide that Dr. Morin already showed. I'm going to focus so on the treatment part, the bottom part of the thing. The molecule itself, it's the same whether we do the imaging part or the treatment part. What changes is the radioisotope. We use the gallium-68 to do imaging, to have the to know if the receptors are there, and then we would simply replace that with the lutetium-177 to do the treatment part, and it also binds to the same receptors. So if we know you have those receptors, then we know we can target your cancer cells. So how it works, we just have an IV, we slowly inject the PRRT. What's complicated is really what comes around it. I'm going to talk about that in a few moments. The molecules, the radiopharmaceutical, goes into the bloodstream and travels everywhere in the body. So it can reach the whole tumors that are everywhere, and it will link to cells overexpressing the SSTR type 2. And then these receptors will internalize into the cells, and when the radioisotope decays, it will liberate what we call beta minus particles, and it will induce breakage, and usually what we want is ideally DNA of the cancerous cells, but it could also damage the walls of the cells. It can always damage the internal apparatus of the cells, and so it will. The goal is to kill those cells. So that's the general principle for PRRT. So an example of response, that's what we want, ideally, what we want. You have to know that complete responses are pretty rare, but PRRT, what it does is that it either shrinks the amount, the tumor burden, or it stabilizes the disease. So that's one case of a very good response. After 4 cycles of PRRT, you can see that the hepatic lesions, all the black spots, have shrunk in the liver, and also other parts of the body as well. The lymph nodes there also shrunk. So that's what, ideally, that's what we want. We're very happy seeing those kinds of response when that happens. So what are the indications of PRRT? So it's been approved by Health Canada following a couple of trials, and it's approved for gastroenteropancreatic tumors, what you call Cnets, if you want. It's not approved for lung bronchial disease or other types of nets you can find elsewhere in the body. It has been used for those kind in different settings, but the data is less firm, if you want. So it's approved for now for adults in well-differentiated nets. Ideally, we want to treat G1 or G2s, those with a high receptor, a lot of receptors at the surface of the cancerous cells. Possibly G3, a couple of, a new study called NATTER2 came out with some preliminary results in January, so showing interesting data for that. You need to have those receptors. You need to be somatostatin receptor positive, so that we need to do imaging beforehand. You usually have to be metastatic or inoperable, because if we have simpler treatments, we will use those beforehand. If we can cure the disease, then there's no place for PRRT. And you have to progress. That's what the government asked. You have to progress under analogs. So you have to have a significant progression. Where we judge significant is, it's a gray area. But usually what we want to see is new lesions or lesions that are growing quickly, quickly. In the terms of nets is relative, but or progressing on SSAs. If it's a couple of millimeters for every year, it might not be the time. We will wait until the disease progresses a bit more on imaging. But it can also mean progression functionally, meaning you have more diarrhea, you have more pain, you have more flushing. So this can be an indicator that we need to start PRRT to alleviate those symptoms. We use the Krenning score, so Dr. Morel already talked about it. What we want is a score 3 or 4, so we want the uptake of the lesion to be higher than liver. Why do we want that? But first, to have a very good chance of irradiating the tumors and make them shrink. You deliver a good dose of radiations to the tumors, and also to minimize the off-targeting. Because as you can see, the dotatate is not perfect, right? You have an amount of regular, if you want, uptake to the liver and the spleen and the kidneys and the bone marrow. So if you have a high tumor burden or have a very high expression of those receptors, most of the treatment will go to the tumor, and less will go to the regular organs. And so you'll have usually less side effects and a good chance of responding. So what are the contraindication? What do we look for? So we're about like 5-6 physicians in TSHM doing PRRT, and this is mostly what we look for when screening the patients. Not everyone is a good candidate. We don't want pregnant people, sorry, but it would be too dangerous for the fetus. Breastfeeding should be stopped. We don't want severe concomitant illnesses. We don't want allergic reaction to the product or even one of the components of it. And severe renal impairment usually is a contraindication as well. So if you're, for example, on dialysis, it has been done before, but it's way more complicated, and we could argue like maybe the life expectancy is not worth it, but it can be discussed, but it's usually a contraindication. We also want a good bone marrow reserve. So we want to have, for example, if you had chemotherapy before, it's way more important to have an hemoglobin that's at a good level, the white blood cells, the platelets, because the PRRT can affect the bone marrow. We also want you to have no significant liver impairment. That can be a problem if the tumor burden is very high. Sometimes the hepatic function is not very good, and borderline, you can have borderline hepatic failure, and we don't want you that the treatment sends you into hepatic failure. So we need to check for that as well. And we want you to have a life expectancy at least 6 months to be able to complete the course of the treatment and to get the benefits from the treatment. If you're able to care for yourself, it's great. If you're only capable of limited self-care, or if you're bedridden or confined to a chair most of the time during the day, then that's not really a good sign for us that you would benefit with PRRT. We have to use caution as well if you have urinary incontinence. It's not an absolute contraindication, but most of the radiopharmaceutical will go through the cancerous cells, but a good portion will come out through the urine. So if you have urinary incontinence or you have a catheter, they have to have like special precautions that we need to take because it can increase the toxicity to the kidneys, and it can have like radioprotection problems if you urinate everywhere or you have accidents. Heart failure is another problem for us, but it's manageable usually because we don't want to send you into fluid overloads when we treat you. You're gonna understand why, because we have to protect the kidneys by giving you amino acids and fluids, so sometimes it can send you into a heart failure, but it's pretty rare, and usually we can manage that, but we have to know it beforehand. So what are the benefits of PRRT? There was a couple of studies, but the one I chose to present is another one in terms of what we call progression-free survival. So they compared PRRT with somatostatin analogs. It was octreotide here, long-acting, versus high-dose octreotide. And you can see the curve separating very nicely. And what we saw is that through the study for G1 tumors and G2 tumors, mid-gut tumors, an increase in nearly 20 months. So it delays progression of the disease. It stabilizes the disease, makes it sometimes regress, and it decreases the risk of disease progression and or death. So those are very good results, and it's one of those landmark studies that led to the approval of the product. In terms of OS, the waters of which is overall survival, not progression-free. So you can progression-free was very interesting, but overall survival, it's a bit of a different story. It started separating the curves, so it was encouraging at first at the interim point, and then at the end, maybe because there was crossover between the two arms of the studies, but it was not statistically significant. There could be an impact on overall survival, but we're not really sure. The data is less solid. In terms of what we call objective response, for example, responses you can measure through imaging, for example, like shrinking of tumors or tumors stability or complete response, complete disappearance of the tumors. If you compare the two arms, there was a clear advantage for PRRT with overall like nearly 18% of objective response, meaning that the tumor like shrinks or either disappears, compared to octreotide, which complete response never happens, and partial response is only 3%. And a good chunk of the other patients who don't have like tumor shrinkage still benefits because it usually stabilizes the disease and improves the quality of life. They have better overall health and functioning as reported through questionnaires. So there's still some advantages. I remember a patient who had like diarrhea like 10, 15 times a day, and he was a farmer. It was very incapacitating. He was living alone, and at the end of PRT, only like 1 or 2 a day, so he was very happy about that. The tumor burden was stable, but for him, the symptoms improvement were a big deal. Recently, we had the data come out in January about a study called NETTER-2 with they did the study with, it's the same kind of study like PRT with somatostatin analogs versus only high-dose somatostatin analogs, but this time for G2 and 3 GEP-NETs, again, the gastroenteropancreatic tumors. And again, the PFS was statistically different between those two cohorts, and you gain quite a number of months between the two. By using PRT, you delay the progression of the disease. We don't have data concerning the overall survival yet, but I'm eager to see it when it comes out. So we could use PRT with grade 2 and 3. It's what it says. It could be an improvement, well, in this cohort for progression-free survival. So what's the typical schedule when you come to see us? Usually we give like 4 cycles of PRT, so every 4 weeks. What we do is that we give PRT, and then you should, we try to synchronize with your schedule of somatostatin analogs. We'll give the somatostatin analogs right after like 4 to 24 hours after each PRT or radioactive injection, because we don't want the two products that target the same receptors to be in competition with each other. So that's how we do it. And so you come to see us like 4 times, and each time it's about the same process. We give, what's long is not really the radioactive injection, it's about like 20 to 30 minutes, but what's long is the whole preparation around it. So you spend about like 4 to 5 hours in the hospital in total. First, we will give you like antiemetic because it can induce nausea. Then we're going to try to protect your kidneys with what we call an amino acid solution. And this will last for like 4 hours, so that's the longest part of the treatment. And in the middle, we're going to give PRT, the lutetium dotatate infusion, and it's over like 20 to 30 minutes. And all the while, you're monitored by your nurse, and at the end, if everything goes well, you go home. So it's mostly like 4 to 5 hours in the hospital. You come in at 8, you're out by maybe 2 o'clock, and you do that like 4 times one time every 8 weeks. So what's our setup, what it's like in the hospital? So basically the patient is lying down, plugged on both arms with IV. It's a bit impressive at first, but you get used to it. On one side, we do the amino acid perfusion, and we give the medication as needed. On the other side, we do the infusion, the dotatate infusion. So we use a separate IV line for that. There's a picture of well, we don't see the patients, we see the system. It's on an infusion pump, like a syringe pump. It'll gradually push the radioactive injection in you. And you'll be in your own room which is like lead shielded and protected to avoid the radiation exposure to other staff. So what are the potential side effects? Most common is nausea and vomiting, but usually the peak, what happened is during the treatment. It's not really the treatment doing it, it's mostly the amino acids to protect your kidneys that will do that. We give premedication to avoid or to alleviate that. It's pretty rare with the medication that it happens during the treatment. It can happen also after the treatment. It could be fatigue after the treatment, could lower your blood counts, your red blood cells, white blood cells, your platelets. Usually it's mostly mild to moderate unless you had chemotherapy beforehand. Then it could be sometimes more sensitive and it could go lower. So we have to test that before each cycle to make sure everything is okay before doing the next cycle. Some mild hair loss. Renal toxicity is about like 1%, and even some maybe less. Hepatic toxicity, less too, maybe 1%. What we look for in terms of severe potential side effects, quite rare, but it could be severe, what we call a carcinoid or hormonal crisis syndrome, but it's less than 1%, and about like 3 years we've been doing that at SHIM. I can't recall like a really severe carcinoid crisis. We didn't have to hospitalize anyone, but it could lead to hospitalization. So we asked patients to bring change of clothes and to be prepared just in case, but it never happened. And we give like about like 100 cycles per year. You could also, if you have what we call peritoneal carcinomatosis, which means like cancer next to the bowels, not in the bowels, but like next to the bowels, in the fat next to the bowels, sometimes the PRRT will create inflammation and will create retractions. It could lead to intestinal subocclusion or occlusion. So we can give corticosteroids to prevent that, but it can happen, especially if you have those disease located there. And long-term, there's a small risk also of hematologic dysfunction. We're talking MDS, myelodysplastic syndrome, or acute myeloid leukemia, about like 1 to 2%, but it happens very late, like about like 4 to 5 years usually after the treatments. So what's different about PRRT? Because the treatment regimen in itself is pretty similar to other systemic therapies in oncology. You can usually have it or take it as an outpatient. It takes a few hours, like chemotherapy. You give pre-medication, post-medication when you're home to prevent nausea and other symptoms. But what's different really is what comes afterwards, after the treatment. Why? Because you'll be radioactive. You won't have superpowers, you won't go in the dark, but there'll be rays coming out of you, invisible rays. So we want to protect that. You have radio protection measure that we explain to you and you have to follow. When traveling, taking, for example, crossing borders, you'll have to have a letter explaining why you're making all the alarms ring, and sometimes you have to take that into account because you can travel, it's no problem, but you have to have a letter saying why you're radioactive, and sometimes they're going to call Washington and ask if this person is okay or not. Usually you'll come through and you'll pass the customs, especially the States, but you have to have a letter, otherwise you'll get blocked. If you were to die during the treatment, not necessarily because of the treatment, but because of the causes, I don't know, heart attack or anything else, special precautions need to be taken for the embalmment and the cremation. You cannot do everything you want with the remains, so it's to keep in mind. So in terms of radioprotection, we ask that people do physical distancing. Ideally, we ask for 2 meters for 7 days for people living around you, so you just keep your distance with other people. And we want to avoid close contact, very close contact for long periods of time. If there are children or pregnant people around you, 14 days is best, and that includes sleeping with someone, so no sleeping with someone for 7 days. Pretty easy. And the other major thing we need to watch out for is excreta management, meaning that you have to, when you go to the toilet, because it's mostly urinary excretion, we ask that you take precautions to always sit down for men. You flush twice, lid down to avoid like splashes of radioactive urine. You wash your hands, basic hygiene, you increase hydration to promote excretion during the first 48 hours. And the radiation will decrease pretty quickly. After about 5 hours, we'll be lost like 45%. So when you go out of the hospital, already 45% of the radiation will be gone. But it can take up to 14 days to get to like 99% or 100%. And some at the customs, for example, up to 3 months post-treatment, they can have very sensitive radiation detectors, so they can detect small traces, so you'll ring. The key takeaway is that PRRT is mostly for inoperable or metastatic well-differentiated gastroenteropancreatic tumors, Cnets, and it's currently approved when you're progressing under regular somatostatin analogs, and it's generally safe and very effective and well-tolerated. Patients who had chemo and that, they're not saying it's like candy, but it's well-tolerated compared to chemotherapy. So it's one of the new exciting development in Cnets. And with the new studies coming out, I think maybe we'll increase our potential, the type of nets we can treat with PRRT. That's it. Thank you. I don't know if you have questions.
Sure, go ahead. Any questions?
Is it? Oh, it is. Okay, cool. Hi. My question is, do we have much data on patients who, like, maybe they had success with PRRT and they want to repeat the treatment years later? Do we have much data on that as of now?
No. So usually, for now, it's like 4 cycles. If you respond well, and by respond well, I mean usually a durable response is at least like 1 year. Without reprogressing, we can enroll you into like a study. Quebec City is spearheading that here, and they might if you're accepted, they might retreat you with 1 or 2 cycles more to see if we can induce another response. But it's not something that's standard. It's not reimbursed by Quebec, so it's under a research protocol. But it's been done, yes, but it's not common. Thank you.
Thank you, Dr. Thank you, Dr. Plusnikov. So that wraps up the morning session. We'll be back at 1:45. Tracy, I'm sorry. You just told me. 1:45. Take your time, and if you can catch the doctors, if you have some personal questions, maybe. We'll see. Lunch is next door.